This would be our March meeting of the Rutherford County Risk Management Committee, and I will entertain, as chairman, I'll entertain a motion to approve the minutes. Is there a motion? Got a motion and a second. All in favor signify by saying aye. Mary?
Mr. Chairman, there's a couple of notations that we need to make changes on the minutes, please, sir, if you don't mind.
Okay.
In looking through them, on page 3 of the minutes, about second, third line down, there's a number of 3 road board members that actually needs to read 7. And in the same, I apologize, that second paragraph down, as the chair, the motion that was made, of course, by myself, a second was made. There was a notation on there that it wasn't, but there was a second made because we had discussion. And I'm not sure how we want to do this. Fourth section down where the chair asked Ms. Hickerson to clarify the motion. The motion stated allowing all spouses on the plan if they do not have insurance. That the do not have insurance needs to be took out. It was just all spouses back on the plan. So if we can just make those notations as we approve these minutes, please.
Okay. Put that in the form of a motion. Is there a second? Any other corrections to the minutes? Got a second. I would assume, Mary, you went back and looked at the tape. You went back and looked at the tape, and these are the corrections in your motion. Okay. Any questions? Seeing none on the motion for correction of the minutes, we have a motion and a second. All in favor signify by saying aye. All opposed? Motion carries. Thank you, Mary. A little bit of housekeeping as we get started. I've had a request that as you speak, there are a few of us in this group, including myself, and our secretary, she's hearing impaired as I am, and since she's taking the minutes, we need to speak clearly in your microphone, so as you're speaking, just get a little bit closer to your mic. So that being said, we thank you. So without objection, members, I have to leave exactly at 2 o'clock this afternoon. I'm headed with our correctional workhouse down to visit with the governor. And so not knowing what the traffic is going to be, that'll give me 1 hour to get to the Capitol. So without objection, I'm going to take item number 9 on our agenda and move it to the front of the agenda so I can still be here for making sure that we have a quorum. So at this point in time, we'll get into the spousal exclusion discussion. So, Lois,
Okay.
would you like to go first?
That item is going to be the final 3 pages in your packet. As we all know, the Rutherford County spousal exclusion was effective on January 1st, 2016. During last month's meeting, there was a concern made that the plan that was available to the spouses had to be ACA compliant. So we went back and checked the language used for the eligibility when we made the change to remove the spouses. The language was, your spouse is only eligible for medical coverage if he or she does not have group medical coverage available through his or her employer. The word group in that denotes ACA compliance, because all group plans are governed by the ACA. So it was ACA compliant. While we were at this, we looked into what other counties or local employers are doing. Shelby County and the city of Memphis added a spousal carve-out as of 1/1/2015. Several other counties have a spousal surcharge for working spouses. Williamson County charges $100 per month. Hamilton County charges $35 biweekly. Sumner County charges $100 per month. And Washington County charges $50 per month. Nissan, which is a local large employer, utilizes a spousal surcharge of $100 $200 per month for working spouses who have access to their employer's plan at an employee only premium of $125 or less per month. So it's kind of convoluted, but it is as well a spousal surcharge. The state plan, we looked into that for local educators, can also have a spousal surcharge, and that's determined by their local jurisdiction. MTSU is part of the state plan for higher education, not the local educators, and does not include a spousal surcharge. So then we looked at some of the data that was specific to Rutherford County. The average county spousal contribution for the 2019 plan year is $463 a month for the health reimbursement account plan and $544 per month for the copay plan. The average spousal surcharge that we could find out there industry-wide is $100 per month. So that would still leave the county contributing up to $404 per month on an average for the spouse after any spousal surcharge was collected, which would be around coming up on $5,000 per year for each currently excluded spouse if they are re-enrolled under a spousal surcharge. The most recent data available when we compare spouse claims to employee claims shows a differential of roughly $3,200 per year, and so that $5,000 a year differential. In other words, the $100 a month spousal surcharge would add up to $1,200 a month, and it would not cover the differential. If you look at the next page, this is a study that Mercer did that's extremely informative. Up on the top line, you'll see that the year that we carved out the spouses, the county saved nearly $8.4 million. That number's a little misleading, that it includes some plan shifts. So I'll call your attention down to further in the exhibit, nearing the bottom where you see a column labeled premium change and an amount of $7,080,939. That is directly attributable to the spousal carve-out. We lost 1,194 spouses off the plan, and we saved nearly $7.1 million in doing so. And then finally, the last exhibit that you'll look at looks like a lot of numbers, but I'll call your attention to the top block, and over far on the far right side at the bottom of those sets of numbers, you should see a yellow block starting with 12.9%, which is what our trends were prior to the spousal carve-out, and then 5.1, 2.8, minus 2.5, and minus 1.9 for our annual trends. That shows that during that time period, the trends mitigated and stabilized. So after discussing this with Director Elam and having a conversation, we would like to recommend that the spousal surcharge stay in place. The spousal exclusion stay in place.
Okay, and that opens the floor for, after that report, Mr. Salvig. I don't think you're on. Hold it a little closer, Jeff.
On the ACA compliant, so a small employer, would that spouse be able to be on our plan?
As long as the plan is deemed ACA compliant, it would be. Now, group plans are required if you have more than 50 employees, and therefore it would be ACA compliant.
What about an employer who is under 50 employees?
That would not, may or may not be ACA compliant. It wouldn't necessarily be considered a group plan.
Thank you.
Other questions? Discussion? Mary?
I know I opened this can of worms last month, so let's just go ahead and swim off in it. On page 3, you were looking in that little yellow box on the percentage of differences. If you'll notice, I understand it and see that we're holding good, but if you'll notice up there, around 2011 or 12, we were at 11.8, and the next time, still with spouses in it, we dropped 4.8, and then we went to a negative 1.8. So we got to remember that trending as long as I have sat here, they've always said you'll have 3 or 4 good years, and then you're going to be stuck with a bad year. And then you're going to have a couple, it's a trend that we have seen. Like I said, as long as I have sat here, we have seen that happen. So I appreciate those numbers, and it does make a difference. When all of this was brought up back in 15, when we were discussing for 16 to be officially said, it was mentioned something about these, keeping the spouses on and charging them, and then it was going to be a, for a lack of better terms, an utter nightmare to keep up with. Well, it can't be that bad now with all the computer ages that we're doing now and everything. And to look right here as we sit, and you got counties that are close to us. Williamson County, I always kind of compare them to us as same size and number and stuff. Their dollars may be a little more coming in than ours. But if they're charging premiums, and if, say for myself, if they're charging me a premium and I put my husband on it, so now I'm going to pay a employee plus spouse, I really think that our county employees would be content with the price increase on the premium because they chose that. But $100 a month, I think that would be a good investment, because some of the guys that we have at work, that $100 a month would be a good investment because they are actually hit for $300, $400, and $500 a month. And they realize that more is going to come out of their check in the initial premium. But to be able to put them on the premium of having a spouse, whether it's plus spouse or plus family because the spouse is in it, I think we really need to look at putting the spouses back on, but yes, having them pay something for it. Because mentioned in the last meeting, honestly, some of the spouses that went off are healthy spouses because they're able to work or somehow have the additional. So we just really hurt the county employees. So I understand your recommendation and I understand the dollars, but in the whole scheme of the dollar amount for Rutherford County's budget, Highway Department, School Board, and County General, this is a small drop in the bucket. And if you're investing in our county employees and even investing in the county as to when I get ready to do a new hire, I can say, yes, you can cover your spouse. Here's your premium, but because we're allowing spouses back, there's an additional $100 or whatever we decide, if we even decide it. But it's really hurt us, and I remember Joe Huffine saying stuff about the ambulance service. It's hard, and maybe the school board teachers, it's hard to get teachers to stay or employees to stay if we're kicking the spouses out and it's costing them an extra $400 or $500 a month for that. So I understand your recommendation, but for in the scheme of things of all the greater numbers, I wish that we would look at putting the spouses back on. They got to pay the spouse premium and putting the additional $100 a month. I mean, to me, that's reasonable because the guys that are already paying their spouse separate, this $100 is going to be a whole lot less out of their pocket, and it'll put more back in for bread and milk. So with that being said, I'd like to make the motion that we put the spouses back on the plan as they were before, with the stipulation of, y'all help me with the wording, if they're coming back because they had previous insurance, that they get the $100, whatever this is called, like Williamson County, whatever that $100 is called.
Spousal surcharge.
Okay, spousal surcharge. If we would put the $100 spousal surcharge on the premium. So for my example, if the premium is going to be to marry, $500 for me and my husband, which would actually be a family, a month, I'm going to pay $500 because now I'm covering my husband and the rest of the family, plus $100. So there's going to be $600 coming out of my check. Whereas before, Mary might have been paying $300 premium, but Mary's husband was paying $300 or $400 at his employer, or having to go down to the insurance company and pick something up. So my motion is that we put the spouses back on at the premium rates that are already to the employees now, but putting the spousal surcharge of $100 a month.
That's in the form of a motion. Is there a second? Have a second. Now discussion. Jeff?
In fiscal 15-16, and the rate increases we were talking about in the first part of 2015, to when we adopted the spousal surcharge, we assumed a 20% move off on spouses. I think Lisa and I both did about that number. It came in closer to 50%. In the second half, January 2016 through June 30th, 2016, we had a budgetary savings in the General Purpose School Fund of $3,968,000. That was effectively, that would be 4 years ago by the time this should come into place. I do not see a tendency to add those funds to the property tax rate. I truly don't. It wouldn't be essentially $4 million now. On the GP fund, it might be over $6 million. And I don't see that happening. Also, one of the counties cited here, Williamson, at least on their teachers, historically, we have paid a substantially higher percentage, even with our drop down to 80% for family coverage, than Williamson County has paid toward family coverage for their teachers. So if we want to look at cutting family coverage or something like, I don't see us coming up with $6 million in the 2019-2020 budget. I'm not a prognosticator, but I don't see it happening at this point in time.
And I'm just
Lisa.
going to follow up, and you know, we do want to look out for the employees, but Jeff and my role is to, you know, we're looking at the employee, what they're having to pay, and knowing that the employee is paying 20% of the premium. That means the county is picking up 80%, so you have this many more coming on that the county is paying, as Jeff said, through taxpayer dollars to fund it. So, I mean, that is a concern for both of us for next year's budget.
Yeah.
So, Lisa, if Jeff says schools would have to kick in $6 million.
6 to 7 million, because again, 4 years ago, by the time this change went into effect, it was just under $4 million. I think it would be
6 to 7. And Lisa, what are you thinking? County General.
In ratio, the same thing. You know,
$1 million.
6 to 1. I mean, it's got 6,000 employees. We've got.
Okay.
Our current property tax what we're looking at for next year for what the value of a school penny is, that would be 8 cents.
8 cents.
Property tax rate. We won't get it through the BEP. We are not seeing that kind of growth in the local sales tax revenue. So that's the only source we see.
Yeah, I was talking, the city is also, and talking to Mayor McFarland, I won't say they're flat. Sales tax rates are flat. However, because of the big boxes are now beginning to close, and so many people are buying online through Amazon and other sources, and that's why there's an important bill in the legislature right now that we're pushing for, so we can start collecting locally sales tax. We do on Amazon, but only because that was a deal worked out that the first 2 years they got here free, but then they had to start paying sales tax on anything ordered in Tennessee from Amazon. But there are so many others outside of Amazon that are not paying sales tax of things that you order online, which could be devastating. Lois, let me ask a question. So how many, with this motion, do we have any idea what that head count would be? are for those who don't qualify, the spouses don't qualify, let's just say they're a homemaker. You know, the reason they were taken off, as they are with the private sector companies, is that if you can get insurance through your private sector, it wasn't fair for the county to pick up the expense when another company should be paying for the spouse.
Correct.
Do we have a head count? I'll get you in a minute, Mary.
The investment in your, when we're making an investment in our employee, this rationale is that by having working spouses on the plan, because homemakers can stay on the plan,
Right.
but if we have a working spouse on the plan, then we are in fact paying for the medical benefits for other employers.
Right, right. Okay, Mary?
Okay, just to kind of go along with, yes, if they're not employed, they can stay on, or if their employer doesn't offer the insurance, they
And I
can
think
stay on.
in previous meetings, that was kind of lost in
Right.
the debate.
Yes, sir.
That it was, you know, the words were saying that they were kicked off back in, what, 4 or 5 years ago, in 16? They were kicked off when really they weren't. They were given, if, you know, we probably, for the record, need to be clear that if they are eligible, their spouse is eligible to get coverage with their current employer, then they have to come off, okay? Otherwise, they're allowed to stay on the plan.
Correct, correct. My question or statement against the money part, the first part is, if we saw these savings as soon as it come off and everything, outside of the county going to ultimately getting to the 80-20 share ratio, if we had that big of a savings and take out the percent of dropping each time, we still saw premium increases. So if we had a savings, how did we see a premium increase? We didn't hold it there and just show the 1%. Every time it was deducted. And then for if the school board, and I had savings. I mean, the highway department had savings too. So basically, you got to ask yourself, if you saved $4 million back then, what you do with that money? You know, if you saved $4 million then, yes, you reinvested it. Well, if you reinvested it into the school board fund, me into my highway fund, I reinvested it into asphalt or pipe. You probably did school books or lunches or something. So,
Hang on just a second, I'll get to you in a second.
so, I mean, if you save that money, we were able to put it back and use it the next time. So now I'm just saying the money that was put back and saved that time, we need to put back into our employee. And I can't imagine anybody thinking that our employees, I mean, you got the employee. I got a truck driver that could be making probably at least $5 an hour more in the private sector working, driving for a company or driving for himself. But instead, the stability of being able to work when it rains and snows and every other day, and having the benefits of the insurance and the sick days and stuff, but he could be making more. But he understands that, and all we're asking is to take care of his family, whether his spouse or her spouse works. We got to take care of the whole family, because when I work here, I take my work home. My husband and my children listen to me, and so they're just as invested into my employment as I am, and it's the least we can do.
Jeff?
What we did, and I think happened on the county side, we budgeted less for medical insurance in the 15-16 year. We initially did it based on a 20% shift off. We also had lower rates when we took the spouses off, a lower budgeted increase. So our total budget was still growing. And then in the 16-17 year, we recognized that our shift off was actually more 50% than 20%. And again, we budgeted less. If you excluded the growth in our employment base because of growth in the county, we budgeted less in actual dollars those 2 years.
Sure. Other questions or comments? You know, Lois?
I also wanted to address the comment, Mary, that you made around, or Ms. Hickerson, around the computers being able to take care of the administration of this, and ideally, that would be true. But in the current format of the systems available to the insurance and risk management offices, we do not have the capability to administer this seamlessly. We'd have to build additional systems in order to make it work and transfer cohesively to the other systems that the county uses as well. Now, in the future, if we can get in the appropriate systems, we would be able to administer it, but at this time, we do not have that capability.
Okay, other questions? Mayor?
If we've made a special group for the county commissioners, road board, and school board as a group of taking their premium, it looks to me like if the employee added a spouse during this, whatever, if we decide this, then we know who that's going to be. And that person can be set up in a group, if you will, just like the commissioners if they choose to get on it. And their fund would just be $100 per person per month. Because my guy, I got mostly guys, that's why I keep saying guys, okay? My guys, I would pull the premium out of their payroll check. So then there would be a special group, just like if my road board takes it, I'm gonna have a special group that I'll have to take that money out every month. This would be a special group with that money every month, and it'd just be, for the simple of $100, it'd be that person $100 a month.
Commissioner Allen?
You know, I always try very hard to be fiscally conservative, and I understand the numbers, and I can't argue with the numbers. And but I just have to add this to the conversation. In the last month, I've been in 10 different schools attending the Title I spring planning meetings. I toured the jail, so I've had access to a lot of Rutherford County employees in the last 30 days. This has come up everywhere I've gone. Everyone has expressed an interest in asking us to support this initiative for what it would mean to their families. So I just need to add that comment to the conversation because it really is going to make a huge difference in these employees' lives.
Lisa?
Back to Lois's comment, Mary, it seems like it should be easy, but it's not easy. Our systems, our legacy system and our office that does the payroll, and speaking to the insurance and their systems, there's a lot of manual happenings that makes it all work. So I understand what you say. It should be easy, but it's not.
Yes, ma'am?
I understand it's not easy to create new systems, but it wasn't easy for 1,194 families to re-budget their household expenses. I think that we can put some time and effort with enough advance notice to put systems in place. I think we can.
I wanted to follow up on Ms. Allen's comment. Ms. Allen, Commissioner, I too have talked to a lot of employees in all different departments since the last meeting, and they have inquired about this issue. But my response to them is I am recommending to the full commission a 2.5% pay increase to lift the entire table. And then I say, which one do you want? I can't do both. I can't recommend to the full commission to do both. It's just we don't have the money to do both. When we have, we're buying property for 2 new schools, we're buying a new $16 million communication system. We are trying to get out in front, but I felt that the best way is to take, at least people would have that expendable income. And I know you can argue that on the other side. Well, if they didn't take it away to pay for my health insurance, then I would have that expendable income. But I think that if we can lift the table for all of our employees, then that will probably be my recommendation. Other comments? Yes, ma'am.
I just had another question. I've been eyeball deep in health insurance for my own personal company for the last month. And so I know one of the things that we do is that we pay a certain percentage for employee only, and then that's kind of our limit, and we don't increase that for employee and family, employee and spouse. Is that any part of a conversation that maybe we could have? I know we've set it so that we do the 80%, but I didn't know if that's worth exploring any further, to change the surcharge, to do something to try to find a way to help make this work. I'm just, I'm always looking at, are there different avenues? Have we explored every avenue of a way to try to achieve a compromise that helps the most people and saves the most dollars? So I'll ask y'all about that.
The current contribution percentages by the county are actually quite good and well above industry standards. On our COPAYA plan, we've been working to get to an 80% contribution by the county from where it was before. It's 90% for the employee, but we're going to be at 81% this year for the 2020 renewal, with an effort to get to 80% by 2021. If you look at the health reimbursement account plan, that one's very rich. We pay 100% for the employee, and we pay 95% for the employee plus spouse, 96% for the employee plus child, and 94% for the employee plus family. So I don't see that there's much room for improvement made on those contributions.
Well, actually, what I was thinking is, do we reduce our contribution in any of those areas to offset the cost is really more what I was thinking. Because, like, for example, on ours, we pay 50% of the employee only, and then if the employee buys up to family coverage, he pays the 50% that would finish his coverage, and then if he buys up to family, he pays that entire difference. So on our employees, and I should know this, but do we pay that 80% at every premium level, whether it's child and all? So
we do.
So that's what I'm wondering is, could we look at doing something where maybe that part of it's not as rich, to offset allowing spouses back on? And I might just be robbing Peter to pay Paul. It might not be helping enough people, I don't know. But I'm just wondering, have we looked at any sort of creative way to, again, like I said, to help as many people as possible with the dollars that we do have?
Well, we've contemplated a few things. One was to work with the rate step, which would automatically skew the type of contributions that would be required you can use that number to move those around. But in addition to that, and it's kind of a blunt object. And then the same with the contribution level. Since we already put in 81%, and that we'll just use the copay plan and say we're looking at the employee plus family rate. The county contributes $1,600 a month towards that, where the employee contributes right here, with the wellness reduction, $375. So if you start moving those dollars around and say the county contributes 70% and the employee contributes, in this case, it would be 20%, or it'd be 30% after you make that change, then that $375 is going to go up significantly, and it would be more than the spousal surcharge that you're discussing. So, I mean, things like that can happen, but it's like I said, it's somewhat of a blunt object when you start looking at doing it in that capacity, changing contributions and rate steps.
One of the things, too, I think, if I remember right, we looked at what the cost would be if it was similar to like how the commissioners were, where they would pay the full premium. But then that was the conversation, too. If the employee got it at their rate and then the spouse was at the full premium, would that really be an affordable, because the premium would be pretty high. And I know that was one of the things we looked at when she started looking at the surcharges at other entities. But that's kind of what, if I'm hearing you right, that's kind of what you're saying. We're still going to take care of the employee, but if the spouse wants to buy into it, they could. Is that what you're saying? Kind of, right?
Yeah, and back to the very first page that I spoke from, if we put in, say, $100 spousal surcharge, that still leaves the county with an additional $404 of liability for each spouse every month. And so that's a lot of money to ask the employee to pick up in their premiums.
Other questions, comments? Well, we're on the motion. Does everybody remember what the motion was? The motion, Madam Secretary, do you have the motion? Okay. Pull that mic over. Okay.
To make a special group, spouses.
It was, the motion was to add the spouses.
Okay.
With the surcharge. With the surcharge.
With the $100 surcharge, okay. Motion was to put the spouses back on the plan as before and add the spousal surcharge.
That's correct. Does everybody understand what we're voting on? Okay. All in favor of the motion, signify by saying aye. All opposed? Yeah, I'll rule that it was a no. I don't know if it was louder or not. Okay. Then we'll move on to the next item on financials. Ms. Miller?
Okay. This would have been the first exhibit in your packet following the minutes. We have, well, first we'll discuss Fund 264, which is the employee benefits fund, the health, dental, those things. If you look at the bar chart, at the top, we have the prior period year-to-date versus the current year-to-date. That's only 2 months of data inherent in these charts. And we were looking at this time last year, a $3.2 million surplus, and this year a $3.4 million surplus at the same point in time. If we look at the fiscal period year-to-date, that's 8 months long, and it totally changes the view. You're looking at a $2.4 million deficit for the prior period and a $2.1 million deficit for the current period. This is easily explained by the fact that 2 months of the premium in the 8-month time period includes the time when school's out during the summer, so we don't have that premium. As that premium comes in, that should mitigate. And I'm at this point in time thinking we're gonna end the year okay. The chart down below with the bar and the red line is simply another way of stating what you just saw, and you can see very clearly those 2 months where the premiums don't come in from the Board of Ed, but it's more than made up in the subsequent months. If you'll look at the next page, this is the same information, just numerically instead of graphically, and you can take a look in the 2019 calendar year revenue, again, only 2 months of data. And as you can see, the margins that we have after that 2 months. We currently have 6,172 employees enrolled, and the average so far for the per employee per month claim cost is $875. If you look down at the other blocks of numbers, you can see now that shows the 8 months of data and kind of flips the data on its head just a little bit, and it shows that $2.1 million deficit through 8 months. But again, we should catch up. If you look at if you go back to like just the first 2 months of the year, you can see that the premiums come in around 1.6, 1.7, and then the rest of the months of the year, the premiums are approaching $7 million. So that tells you the differential between a regular month and those. We've only got a $2 million deficit. We're looking at probably about $1 million per month to come in over what average claims have been, and there's 4 months to go. So at this point, it's not looking like we're going to have a problem. And we will be discussing the 2020 rate projections later in this agenda. If you go to the next page, that's the Fund 266. This is our work injury fund. I can tell you from looking at the data that this year claims are running about $140,000 behind the same time last year. And if you look at the differential between workers' comp and OJI costs, down in the second graph, you can tell the workers' comp is in the blue. We had a very large workers' comp payout in October last year, so that caused a large spike. And the OJI has been much more stable. And then the final page is the numerical representation of those graphs for Fund 266. I'll call your attention to the two boxes that say year-to-date, the yellow one and the one directly below it. That shows that $140,000 claim differential through the first 8 months of the year. And that's actually about 78% of where we were last year. And so we've got some stability, or at least some better experience going on in the work injury fund now. Any questions to those?
Mary?
Okay, the October large payout, that was that closing a workman's comp claim?
No, it was not.
Okay.
And we still have 6 workers' comp claims open. We had 8, we closed 2 recently, but there are still 6 open.
Lois, when you talk about having claims open, do we have any that have lifetime medical that won't close?
At least one that I know of. I mean, any more than that?
All 6 are open.
Okay, all 6 of the workers' comp claims.
Or lifetime medical?
Any other questions on the report? Seeing none, I'll entertain a motion to accept the financial report. Motion to approve. Is there, Mary? Is there a second? Jeff Phillips on the second. All in favor signify by saying aye. All opposed, motion carries. Next on the item agenda, we have Mr. Good. Dan, you're recognized on the OJI. Yes, sir.
Good afternoon. Reporting for the month of February, we had a total of 15 injuries requiring medical attention across the county. And you look at your report, you can see the breakout there for the different types of injuries. That brings the year-to-date total to 28. Of those 28, 18 of them are recordable, OSHA recordable, and 8 of them had restricted days, 4 were lost time days, and 6 were all others. For the month of February, the incurred dollars was $13,650 for the 15 injuries. And as you look at the first graph of your report, you'll notice that for this month, or year-to-date, we've had 28. Last year at this time, we'd had 44 injuries, and in 2016, we had 36 injuries at this time. So we're doing better as far as injuries this year. In addition, as you look at the next page, you'll see the incurred dollars. The total incurred dollars this year so far is $40,000 compared to $211,000 last year. And that's last year. We had some bad weather in the month of January, had a couple of injuries that pushed that up. And in 2017, we had $60,000 incurred dollars at this time. Of those injuries, 9 of them were with the Board of Education, and the incurred dollars there was $5,580. The county had the other 6, and incurred dollars there, $8,070. And as you look at the last page of your report, you'll see across the county that those injuries, those 6, were divided up between the Sheriff's Department, Fire and Rescue, and Animal Services PAWS.
What would a miscellaneous accident be?
I'm sorry?
What would a miscellaneous accident be?
I'm not sorry, I don't.
There's miscellaneous causes? What would that be?
Miscellaneous. It's something that doesn't fit in, like it may be, it's not a slip, trip, and fall, it's not somebody didn't get struck by something, or something like that. It just doesn't fit into any particular category, so it kind of hangs out there by itself. I'm sorry? No, dog bites would be in struck or injured by. Let me see here, see if I can think of one real quick. In the jail cell, an individual has body matter thrown in their face. So that would be a definite injury we need to take care of, but it really doesn't fit into any category.
She regrets she asked that question. Anything else, Dan? Any questions for Dan? I got a motion. Is there a second to approve the report? And a second. All in favor, signify by saying aye. All opposed, motion carries. Thank you, sir.
Thank you.
While we're on workers' compensation, can I ask a question about budget? Each department probably puts together their own budget as it relates to work-related injuries, that total fund. Who comes up with that, Lisa? Who comes up with that figure? The department itself?
No, I do. On how to fund it, the amount that...
Like for the school board, as an example, they have a particular budget for workers' compensation every year. They don't put that together. You put that together?
It's actually the same number we've had for some time, and then we look at it every year to say, can it be adjusted? It's compared to, I do a comparison every year of how much money the highway, schools, and county put into the fund compared to costs incurred by each division. He's got that, and so we've got it back to 95.
Yeah. And the amendment we had the other night at Health and Ed, this year and the previous year, because our claims had been trending better, Lisa was comfortable with us. She wanted us still to budget the amount we've been budgeting in recent years, $527,000, but we only paid half of it last year in this because our claims are doing better, but it hasn't been. Are you looking at like a 10-year trend on that?
Actually, I'm looking at the entire period from inception to how much the claims actually were by fund to compared to since 95, how much each segment of government, what their claims were. And the reason why that he was able to reduce on schools is because the county has had more claims over that period of time. And actually, the reality is the school has paid more than their share in. So we're trying to, over time, have the county pay their part.
I guess what I'm trying to get at is that we budget a certain amount of money. It's this guy's job to make sure that our workers' compensation program is up to date and that we're addressing those injuries, hopefully reducing them year after year. And Dan has done a really good job since he's been here in doing that, okay? And my concern, I don't know if it's a concern, but my question right now is if we budget, like in the highway department, if we budget $100 for the workers' compensation and they have 0 claims, what happens to that $100 specifically designed for work-related injuries?
One fund, all the monies go into one fund. I've accounted for all the monies that the highway fund has turned into the fund, to the OJI fund, compared to the claims they paid. So if they have none, it just accumulates on their side. Now, going back to your question on how much is determined, we have to have an actuarial study done on all the insurance funds to make sure that what we have and set up as our liability is actuarially determined.
I guess maybe you realize where I'm going with this. If we realize savings from that fund, in a particular year, where does that savings go? That's what I'm asking. What do we do with that money that we had budgeted?
Okay, typically, if everybody pays into the fund, and there is savings all the way across, I mean, it stays within the fund. There are years I've told Mary, don't pay it. Don't pay your, she's got it budgeted, but I'll tell her don't pay it. And for the last 2 years, I've told Jeff, only pay half. So where is the savings? Sometimes it's sitting in the fund, and sometimes it's sitting in their operating fund.
One of the other things we have to watch, Lisa and I do very carefully, is we cannot, education funds have to remain education funds. That's one of the big no-nos that we have to watch out for. So she does it within that fund, but we have to be very careful that education funds stay designated for education purposes, and you've got some of those constrictions.
I think Mr. Phillips is maybe trying to get, let me kind of make a run.
Let me make this perfectly clear, Mr. Mayor.
Yeah.
If we save $250,000 in that fund that's set aside, shouldn't that fund go back to the county's bottom line?
Not exactly the counties, because it would go the lion's share to schools, small little share to highway.
Actuarially, we have to be funded.
But actuarially, we have to be funded.
I have a concern about using those insurance funds, workers' compensation funds, for operating expenses. That's
It's not. It's not, because once it goes into the fund, it stays in the fund. Do you understand?
Can you explain that transfer that we had in the health and ed the other night? Can you explain that?
Never came into the insurance fund. It was budgeted in the school's operating fund. It did not get transferred to the workers' comp fund. Once it goes into that fund, it stays. We're not transferring out of that fund.
We also have the liability. One of the other funds we also look at very carefully is the self-insured portion of our liability and property casualty expenditures. When I have unexpended insurance funds from the budget, as we get late in the year, we will be looking very carefully at what potential liabilities we have out there, and that's when we make a determination, okay, we need to send that to the self-insured liability insurance fund, property casualty fund, to account for these potential claims we've got out there, and build the reserves, and the auditors evaluate those reserves to make sure our reserves are all right. It's a similar.
Maybe I didn't make myself really clear, but I think certain funds like that, if there's savings, probably should go into some ending fund balance situation instead of moving it around to purchase something else within a particular department or the school board or something else. It kind of, to me, it just doesn't sit exactly right.
If we have a situation come up like this attendance software conversion that we could not have anticipated last year, I thought it was a source of money it was some money we would not be writing a check for this year, and I really thought that was a decent source, because the feedback I've gotten from the county commission, we're getting off the real insurance committee business, is they do not want me coming in from ending fund balance.
Mary.
Just to make it simple, because I'm a very simple person, just for easy numbers, Jeff, I have one workman's comp line item for the highway department, $60,000. Once a year, Lisa says, I need that $60,000. I write a check to Rutherford County Workman's Comp, $60,000, give it to Lisa, they deposit it in that account. Same way with the liabilities. Now, I don't see it and I don't want to see it. But when there are payouts to the doctors or the people or whatever, Mark or whoever's in charge in the finance office is running a total on my $60,000. Did I use it all up? This year, knock on wood, I've not used up my last year's $60,000, so Lisa hasn't asked for it. Now, if I don't write that $60,000 and I'm to the good at the end of the year, $160,000, because I didn't write that one, that $60,000 that showed up out there that I might spend it and didn't, that's going to be part of that $160 that goes into my fund ending balance. I look at it that way because I have to explain it to my road board members what happens to it. I'm like, okay, it goes into a checking account over here for work comp only. We got a tally sheet on it, and I'm going to check off the checks and make sure it's balanced, and when it runs out, I send them another check, just like I do for liability. So for simple purposes, it goes in there, and if I don't use all my $60,000 this year, I won't have to pay her. Next year, I'll probably have to, because knock on wood, I've gone 1 year now without having to pay it. So yes, and just to say out loud, Dan has done a wonderful job on keeping the OJI workman comp's claim down for us.
Actually, just trying to get it clear in my mind, if we're saving a lot of money on workers' compensation, how can we tell from a budgeting perspective that we are saving that money and budgeting for that year after year?
See it in his one line where he pays it, and in Mary's one line where she pays it.
I don't know, I think you got your point across. I think everybody you worked it out.
I understand it a little bit better.
Sure.
Once again, the private sector where I came from, and I know where Jim came from, everything zeroes out, okay? If you save $1 on workers' compensation, it's $1 profit for the company, $1 profit for the company. And that was my question. Where does that savings go? And
Part of the difference, Commissioner, is when I was in private industry, that's the way it was. We are very, well, we're so we have to look at we have to keep reserves on our books because we are self-insured. If it were a premium product, we wouldn't have to. But when we were on that approach, we probably were paying out more money than we are now. So.
Okay. Any other questions for Dan? OSHA report? I'll entertain a motion to accept the report. Oh, we already did. Already voted on it. Okay. I've got about 2 minutes. So I'll go. Let me just take a minute before we get into the wellness update. I probably need to walk on downstairs. Mary, if you won't come up as vice chairman, as she's making her way up. I was remiss in not officially introducing our new director. And I was going to see how he was just going to kind of blend in, and he did well. But let me introduce our new director of risk management and insurance, Mr. Ed Elam. Ed, we're glad to have you on board. Lois has committed that she's going to stay as long as he needs her. And I know just this week, he started on Monday. Ed had a long history of serving this county. He was on the county commission back when I was in the 90s. I think he stayed a little longer after I did, but he was also a long-standing member on the planning commission, so it's not like he knows our county very, very well. He spent over 20 years in the private sector, and now is coming back, and he dealt with OSHA. He dealt with fleet and property and casualty insurance, and he also dealt with benefits as well from the company S&W Electric that he retired from. So this is a great opportunity, a very knowledgeable man that we're blessed to have taken over the position of our risk management and insurance, and I say welcome. Plus he's a Blue Raider, so I like that too. Yeah.
Yes, thank you. I just want to thank you very much. I want you to understand that this office serves the people, the retirees, the employees, the citizens, and anything that we can do to help you, you're more than welcome to call us, give me a call, and we'll do everything we can to help you. Thank you.
All right, looks like we are for the wellness update, and Mr. Chuck, if you'll come on up and get us started, please, sir.
Good afternoon. The 2019 incentive campaign is in full swing. We're seeing some great numbers coming out of that. Currently, for annual physicals completed year to date, we're at 544. We have completed 1,035 biometric screenings have been completed. Health assessments online have been completed 374. We've completed 478 mammograms, 686 OBGYN screenings, 193 colon cancer screenings, 637 cervical cancer screenings, 174 prostate exam screenings, 1,684 flu shots, and currently to date we're at 1,502 full goal completions. And to reiterate the program requirements, it's 3 points per individual. If you have a spouse, they have an additional 3 points, so 6 points total if you have employee plus spouse. So to date, 1,502 individuals have completed all of their requirements for the year. Moving into current events coming up in April and May, we just wrapped up our last wellness program. I'm proud to say that all participants had about an average of a 5% weight loss. And to put that into perspective, a 5% weight loss has actually been shown to improve things like blood pressure, cholesterol, your blood sugar levels, things like that, and also can reverse or stop certain risk factors for chronic disease. So it can change your status if you were diabetic at a 5% weight loss. So to achieve that level with just our participants over the course of 6 weeks is excellent. Obviously, we've had people that went above that and a few below, but the average lost was enough to affect those risk factors and to see that kind of thing. So you always want to see that when you do a wellness program, to see that kind of outcome with that. We are firing up the Wellness on Wheels, and again, just to go over what that is, we go into each and every site at Rutherford County to include the schools, and we just continue to promote the 2019 Wellness Incentive. We make sure everyone understands. We're there to ask questions. We're there to provide feedback on any of these things and just to help educate the population in that. Any issues we see, we keep track of, and that way we can backtrack and fix those in the systems as well as we come across. So we're firing that up. We're actually going to the sheriff's office next week on Tuesday and Thursday. And so that will start us reaching out to Board of Ed and other areas in that regard as well. So we'll be very busy starting very soon. This month's Life Services EAP webinar, it was available March 19th. It's on interpersonal communication for social skills and success. That's available on demand. The upcoming one for April will be Understanding Resilience, and that will be available on demand starting April 16th. And then the one for May is going to be the Healthy Mind Toolkit, and that will be available starting on May 21st. Do I have any questions?
All right, seeing no questions, do I entertain a motion to approve the report? A motion and a second? All right. All those in favor of the report on our wellness program, please signify by saying aye. All those opposed? All right. Thank you, Mr. Chuck. Appreciate your report. All right. Now we're going to call on a MedPoint report, and we'll get Ms. Shannon to come forward, please, ma'am. Good afternoon.
Afternoon. You guys probably have 2 packets for us. We're going to start in the MedPoint Clinic's February report and go over our numbers for February. On the first slide, you will see in February we saw 1,238 visits, and I would just like to call out again that that does include some non-face-to-face encounters, but as previously stated last month, we're not able to capture 100% of those non-face-to-face encounters, but that's an increase from 1,133 in January. The next slide is a quick snapshot on our wellness visits. Our wellness coordinator in February saw a total of 45 visits. 42 of those were follow-ups with 3 initial visits. My registered dietitian saw 18 visits with 13 follow-ups and 5 initial visits. The next slide there is the per employee per month summary. For February 2019, total operating cost was $222,011, and that averaged out to be $36 per employee per month, with an employee count of 6,172 for the month of February. And then the last slide will be our incoming calls at MedPoint. We had a total of 1,743 total incoming calls with an average of 87 per day. We did hire an additional person administratively to help with the phone calls, and I think that's why we see a good decrease in those numbers there, because we have someone dedicated that is not checking in patients, that is just answering the phones there at the clinic. So we're definitely seeing that decrease, and we hope to continue to see that trend. Any questions? Okay, the next packet that you have from us, the MedPoint Clinic's My Premise Health. I had met with Ms. Miller, and she thought it would be a great idea for you guys to just see some screenshots of our new My Premise Health app that we have. It's our online patient portal. Some of the great new things that we offer with this new patient portal is virtual health. So you guys can make an appointment online. If you have a smartphone, you can download the app on your phone, and you can have a visit for certain visit types right there through your phone. The provider can see you, you can see the provider. It's basically like FaceTime, but for a visit with the MedPoint clinics. And so that's a new thing that we offer with this new My Premise Health that we have. So I just took some screenshots of the app, and you'll see that in this packet here. The first one is just the sign-on page that we have for the My Premise Health. That's the look and the feel of it. The next one is when you sign on to your account, that's exactly what it looks like. So you've got in the top left corner beside My Premise Health, that's the that's a test patient, but it would be your name there. You can also get proxy access to family members. Anyone 17 and under, children, the legal parent or guardian can have access to their account through their personal account. So you don't have to have an account for every single person that is 17 and under. You can do it all through your personal account as their parent. You would just change it right there and change it to that person, and you can make an appointment for them. You can message your provider. You can look at test results, all of that through this app. The next screen, I just highlighted what is under the health tab at the top, and it just talks, again, those test results, your medical history, immunizations. There's questionnaires. If you are coming in for a visit and you want to answer a questionnaire based on your symptoms, you would find that there. And then on the next page, under the messaging tab, that's where you would message your provider. If you needed to ask a provider a question, you can request a medication refill all through this app. A lot of great features in this new app that we have. Also, on that last page, that's where it says request minor chart access. That's where you would click to request access for dependents 17 and younger. Any questions?
I got a question, Ms. Shannon. How easy is it for a new user to sign up? If they go to this new user sign up now, if I'm sitting at home, do I have all the information I need to be a new user, or am I going to have to call you and get a code to get started?
Sure. So we did send out information back in November regarding the sign up for this. Employees only are able to access without requesting us to grant them access. You can email us, so if you're not the employee, you just need your social, date of birth, you can put it all in the system and create your username and password right there as the employee only. If you're a spouse or an adult dependent and you need it, you would just email us at medpoint@premisehealth.com and just give me your date of birth, your name, and you want to grant access. I can send you a text message, I can send you an email. It has a link, you click on it, and with that link, you would sign on. So
Okay.
you have to have the link if you're a dependent or spouse.
Okay, great. Thank you.
Okay. Any other questions? Thank you.
Thank you. All right, looks like we're going to get with Ms. Lois Miller on the FSA bids. Ms. Miller?
Yes, this is simply additional information. I think at last month's meeting, we told you that we were going to let this bid, and it was released on March 6th. We've had very good interest in it. We've had letters of intent that have been received by 7 different vendors. WageWorks, who is the incumbent, they currently have it. Cigna, Discovery Benefits, Health Equity, Task, Payflex, and Navia. Anyway, I was really pleased to see 7 different vendors. The bids are due next week, and we'll be picking them up at the purchasing meeting, in which after that they will be taken under study, advisement, and Jay Brown and his team at Mercer will start going through those to see who will make it to the finalist interviews, which will occur between April 17th and 19th, and then there will be a finalist presentation to the Risk Management Committee next month at the April 25th meeting. Insurance and Risk Management Committee. The final decision is to be made by May 16th, and the effective date for this will be January 1st, 2020.
Thank you, Ms. Miller. Looks like a plan. All right. Looks like we get to go to the big sheet for our January 1st, 2020 on medical, dental, and vision renewals. Ms. Miller.
Yes, and boy, do we have a lot of information for you here, but I'll boil it down to tell you that we have a very reasonable renewal for 2020 for the benefits. What you're going to see as you go through these sheets is that there's a consistent 5% increase to the copay plan, and this is our last year of trying to bring the county contribution down to 80%, so we're at 81%, and next year we'll be at the 80%. There is a consistent increase of 7.5% to the deductible plan and a 2% increase to the health reimbursement account plan for active employees. And as you look through there, we've highlighted the 2020 total premium rates and what the increase would be to the employee. And they're set out by, the first page is for the county, so it's a 12-month page. The next page is for retirees. And the retirees have a 50% contribution for the most part. And then the third page is for the active employees of the Board of Education. Those rates are different, of course, because they pay on a 10-month schedule instead of a 12-month schedule. But again, it's 5% to the copay plan, 7.5% to the deductible plan, and 2% to the health reimbursement account plan. The one thing I would want to point out to you in the deductible plan, that this plan has not been performing well historically in fact, for several years now. We're down to, when you add up the enrollment between the county, the Board of Ed, and the retirees, there are only 441 total employees still enrolled. If that drops to less than 300, the plan will no longer be viable, and we will be forced to cancel it at that time. So if the enrollment drops down below that for 2020, of course, since we've offered it, we'll keep it open, but then it would close at the end of that year. And if you move deeper into it, then you will see that you have the dental renewals. And the dental plans will renew with a 1% increase across the board. The only thing to call your attention to here is that the buy-up Option 1 buy-up plan will be terminated effective 1/1/2020. This has been in the works since last year when it was voted on, and so that shouldn't come as a surprise. There will be a 4% increase to the DHMO. So the self-funded dental plans are 1% and a 4% increase to the DHMO. Layout is still the same. The highlighted columns are the 2020 total premium rates and the increase to the employee. And then the dental rates for the Board of Ed are laid out the exact same way. It's just over a 10-month time period instead of a 12-month time period. And the final page of the exhibit is the vision renewal rates. There will only be a 1% increase on those, and the county and Board of Ed are both represented here. Questions on the medical plan?
Yes, sir, Mr. Phillips.
If there are things that are being added to the coverage, and I can't think of what one may be, but let's just say that, as an example, retainers or something under dental, if they were to be added to this plan, how does that happen?
Well, we'd have to go back to the carriers and, well, first of all, we'd have to get a price for it. We'd have to get an actuary to give us the value for that, and that would probably come from Mercer. And then we would bring it back before the committee and have them debate it and determine if it's appropriate for the addition. And then it would be, if it was approved, it would be added into the plan. There may be some rate impact, so we'd have to go back and revisit the rates if that were to occur.
So an additional coverage or even some coverage that was being dropped or recommended to be dropped would all come before this committee?
Correct.
There's some kind of justification in that we usually present if we're going to add some coverage. Is there some justification? This is why we want to do it?
Yes, it might be a trend in the health insurance world that some new thing is covered. It might come from an overwhelming request from the employees. And in this one specifically, on the dental, removing the option 1 buy-up, that went through the committee last year. The reason that we would want to remove the deductible plan on the medical side is because it has been performing so poorly for several years now that the enrollment is winnowing. Indeed, it is grandfathered, so we can't take any new enrollment in that plan, and anybody who leaves the plan cannot go back to that plan because it's a grandfathered plan, and it's in what we term in the industry as the death spiral. It's got a lot of adverse selection going on in there. Now, this last year, when we had the enrollment, because of the continuous increases in this plan, if you look at these rates, you can see they're clearly unaffordable. And because of that, the enrollment in it dropped by 60% from 2018 to 2019. We saw equal percentages of those, or roughly equal, flowing into the copay plan and the health reimbursement account plan, which showed that there was good acceptance of both of those other plans. And so we're pretty comfortable with that these folks who are in this plan can find another home if we are forced to drop it because of a further drop in enrollment.
So if we wanted to add a plan, and I'm just going to say like braces under dental, if they weren't covered and we wanted to add that coverage, that would have to be full disclosure before this committee, correct?
Correct. And
what we want to do, and this is how much it's going to cost, and why we want to do it.
Correct. And we do have braces under the dental. But yes, any benefit that's not currently there, we would, like I said, we'd have to have it priced and then determined whether or not the committee approves or disapproves.
Thank you.
All right. Mr. Phillips, just to clarify, our dental and vision are freestanding policies that they go out and buy. I can speak to both. I have both. We purchase directly. There's no county matching or any funds for our dental. So our dental and vision is a product offered. Right now it's through Cigna, so it's what they cover for the plan that they offered. Now, our medical being self-funded, yes, sir, anybody can come here and ask for us to cover something. As long as I've said here, we've had TMJ brought for a medical instead of dental, and it goes through here because they've shown that trending, it's starting to cover this more because of the adverse effects on things like that. So we as the committee have a say on our self-funded medical plan of what we do and don't cover. And it comes here, and ultimately the 21 commissioners votes on what the plan says. But our dental and vision are product-based. We go to the market and we get their product they offer, basically. There's some tweaks to it, but we don't have near as free for the dental and vision of what, I want glasses every 6 months instead of every year, things like that.
Madam Chairman, may I clarify?
Yes, go ahead.
The DHMO plan that is listed on the dental rate sheets is indeed a fully insured product, and we are dictated by the carrier as to what can be included in that product. Option 1, the other dental plans, option 1 and option 2, while they are fully contributory to the employee has to pay the full rate. They are self-funded, but we still have only a select choice in benefits, and the rationale for that is these plans are pretty standard throughout the industry, and so that's how they're sold. They're sold with specific sets of benefits. So while the Vice Chairman Hickerson is totally correct in how the benefits are developed, we do have some bit of flexibility in the self-funded products.
If I could make completely clear that you don't have the authority to make any changes without going before this committee, correct?
That is absolutely correct.
That's pretty much what I was asking. We've got a new mayor, and if our new mayor said, my kids need braces, I want you to make darn sure they're covered this, all of that stuff would come before this committee, correct?
That is correct.
And I don't mean to say that Mayor Ketron was doing that at all, but
Oh, understood. All right, are there any other questions? Ms. Miller, would it be easier if we took all at one time or each? I'm sorry. Yes, Mr. Samby.
This really is for the enrollment materials that we prepare. Last year, since it was a grandfathered plan, the deductible plan was not included in the materials. I think there was a thought that it might create more doubt. As a result, I think we had employees who perhaps if they had seen the rate increases, if they had looked at their enrollment materials, would have additionally moved off. I think we've had some who've been rather upset by the hefty rate increases that they saw. That very clear to them.
Yeah, and I would agree that we need to do additional education around the entire health benefit plan for all of the employees so that there's a better understanding. So we'll build that in.
Any other discussion? Yes. Yes, Mr. Phillips.
one other question on the timeline. It says final decision May 16th, 2019. That's a final decision by this committee?
That's for the FSA, yes. Actually, what will happen is, let me go back to the FSA paperwork.
This would go to budget in April, and then y'all, I say y'all, your 21 commissioners will vote. Now, that FSA schedule, that's not the renewal schedule. The FSA was for information purposes, and it'll come back in April for us to look at the bids and decide on the flexible spending account. It's just flexible spending account. That's kind of like already done for this month. We'll bring it back next month with the suggestions of who, and we'll probably listen to a presentation and make a decision, and that will go. These renewal rates that we have looked at will go to budget. Is that right? Will go to budget in April for a 21 commissioner vote in April also. So, yes, sir. No, sir, these renewal rates will go in April because me and Jeff and Lisa need some tighter numbers in projecting our matching and premium on our rates for our budgets. Yes, sir. Okay. Actually, we should vote on all four at once. Oh, have you got, oh, okay, I'm sorry, do we want to, what have you got, what else you got, hon? I'm sorry.
So the next set of, the next part is also an increase, the increase of the stop loss.
Are we voting on everything, the rate things together?
Yes, that's what I intended. So the next part of the plan renewal is the stop loss. The stop loss is the coverage that protects the county against catastrophic claims. We are currently at $750,000, which means that any individual claimant can claim up to $750,000, and that claim is the liability of the county. As soon as it rolls over $750,000, it becomes the liability of the insurance carrier. And so we went out and got the renewals for that, and again, we're at $750,000. They came back with 4 different options: to remain at the $750,000, to go to $800,000, or $850,000, or $950,000, and then, of course, there's savings. If we stay at the same, we'll have a small increase of $26,000. If we move it to $800,000, we'll have a $44,000 savings. If we move it to $850,000, it would be $103,000. And if we move it to $950,000, the savings would be $193,000. But it's very important that you understand that each of those savings levels are offset by a $50,000 increment to our claim liability. Now, this year, we're having a wonderful year in the stop loss. We've only got 1 claimant so far that has exceeded. Of course, there's time left in the policy year, and it could definitely go up, but we only have 1 claimant. I think back from my years of service before, we used to average 3 to 4 per year, and so I would recommend actually for this year, given the fact that the other renewals are as reasonable as they are, that we accept the renewal for the $750,000 level with a $26,000 increase, and we take another look at the other options next year. That $26,000 increase is baked into the rates that you just reviewed.
Yes, Ms. Sonia.
If we went with the same policy in the renewal, we would be losing the unlimited maximum, though. Is that correct? We're going from unlimited to $2 million. Is that correct? Is that what I'm reading?
Yes, with the renewal.
So it is kind of a lesser benefit than what we currently have, right? Right.
Yes, the chair will call on Mr. Huffine from... Okay, so currently, instead of unlimited, we're at $2 million. So really, okay, absolutely no change outside the increase. Okay, thank you. All right, any more discussion or questions?
Stop loss?
On the stop loss? All right, are we?
Oh, no, we got 2 more.
Got 2 more? All right.
We're getting all the rate changes through today.
Okay, before we get started, this is renewal at the price with the same vendor on them, on each of them, right? We're not changing vendors.
We're not changing vendors, that is accurate.
That way everybody is knowing that when we vote on these, this is the current vendor we have, so we're not changing vendors. So that's how we can kind of put them all together. Okay, sorry about that, Ms. Miller, go ahead.
That's fine. So the next one is our short-term and long-term disability renewals, and the vendor on that is also Cigna, and the renewal is a rate pass, no change in the rates, with a rate guarantee of 2 years. And just to keep in mind, the short-term disability is voluntary. The employees purchase that. The long-term disability is paid by Rutherford County.
Any discussion or questions on the disability, short or long-term disability renewal rates? All right, we'll go with the next one, Ms. Miller.
Okay, the last one is our life insurance. This is a little bit of a story, so bear with me. Our current life insurance company is Standard. They've had the product for 2 years. They are experiencing large losses under the product for the 2 lines that are highlighted, which is the active basic life and the spouse basic life. The active basic life is the $35,000 in coverage that Rutherford County provides for each employer. The spouse basic life is a voluntary coverage. It's purchased by the employee, and it can be anywhere from $5,000 to $25,000. They can purchase up to that, and so anyway, those 2 lines are the ones that are not performing very well. Had some concern about the rate at 3.5 cents. That's the current rate. You see that 0.035, that's 3.5 cents per thousand. That is very low for life insurance policy. The proposed renewal increase is 8.1 cents per thousand. That sounds like it's really grown a lot, but we need to keep in mind that 8.1 cents per thousand is less than what the prior carrier was charging us at 8.9 cents per thousand. So it's still a savings from where we were 2 years ago. While this increase does seem substantial on the appearance of the losses that they're having, they're not looking to go back and recoup their losses. They're looking to just be made whole going forward. So for that reason, it's a reasonable renewal. It adds approximately $10,000 per month to the county's costs. The other line, the spouse basic life, is currently at 32 cents per thousand, and it would be going to 40 cents per thousand. If an employee took out the maximum amount of $25,000 for their spouse basic life, it would be an addition of $2 per employee per month to the employee.
All right, we have any questions on the basic life renewal?
I'm still new and kind of learning, and I'll never be where you are, Mary, never. But
Please don't.
This is strictly term life insurance, correct?
Correct.
And not convertible in any way?
It is convertible. If you were to lose your employment and needed to take the insurance with you, you could. However, at that point, it transfers to an individual policy. And an individual policy, by its nature, is much more expensive than a group policy. And so you would be asked to pay the amount that would be appropriate to your situation as an individual. Generally, people don't find that affordable, and so so while it's portable, you can't always take it with you because you just don't want to. It's too expensive.
So if an employee retired with, let's say, 30-year service, and it was an early retirement before normal retirement at 65, they would lose their life insurance but could convert it.
A retiree is a little bit of a different animal. They can maintain a group rate. Yeah, they do get aged out sooner. They do age out at a more rapid rate than the employee does. And that comes with, as you age, the insurance becomes more expensive, but instead of being more expensive for you, they say, okay, at this age, we drop your coverage by 25%, so you only pay for the new amount of coverage.
So that coverage extends beyond 65?
Correct.
Okay.
And just for your note, there are some age difference, even if they're an active employee.
Yes.
If they're 70, they're covered at half, and then if they're 75, they're half of that, and the premiums go down. Just for your information, for still active employees, and I have some. So,
one of the reasons I asked that is because I'm 70, and I realized that increase in the rates, which kind of pissed me off, but it's neither here nor there. I just wondered if this was term, and I'm assuming that it was, and is it convertible? So someone, even though they may leave the county, would still have the option to purchase some life insurance through this plan. Not through this plan, an individual plan through the same company.
Correct.
any more discussion on the life insurance? All right. Are we through, Ms. Miller, on all our renewals?
That's it.
Okay. All right. So we have renewals for medical, dental, vision, stop loss, disability, short and long term, and the life insurance. What's the will of the committee? Mr. Sandvig. Motion by Mr. Sandvig, a second by Ms. Christie. And any more discussion? All in favor of approving all the renewals as presented, say aye. Aye. All those opposed? Hearing none, motion passes. All right, so our next item is going to be pharmacy management programs. And Ms. Miller, are we calling on Mr. Paul or
Mr.
Mr.
Huffman
Paul
will come up,
Huffman?
yes.
If you'll come forward, please, sir. Paul, if you don't mind, introduce your helper there, please, sir.
All right, good afternoon. I'm Paul Huffman, Senior Account Manager with Cigna. Ms. Miller asked us to come here and talk to you about a couple opportunities with our pharmacy network and our pharmacy formulary. These are opportunities that you as a committee can make a choice on if you want to implement at some point in the program. Our job right now is to kind of give you an overview of what these two options represent, the impact of them, and the potential savings that the county could reap if you chose to do so. So I've brought with me our pharmacist, our pharmacy consultant. This is Dave Brado. And if you have this packet in front of you right here, the one with pharmacy opportunities, we'll start on page 2, and I'll let Dave start with the first one, Cigna 90 Now. And if you want to, sure, I'll jump in and help him where he needs me.
Good afternoon, everyone. Actually, Cigna 90 Now is a more improved, more affordable network based on deeper discounts we're able to get with contracted pharmacies in the 90-day network. And you can see on the left-hand side, there's 29,000 pharmacies within that network currently, which includes CVS, Walmart, Kroger, Access, Good Neighbor, Cardinal, and all their subsidiaries also that are listed there, along with each of those bullet points. It also includes a larger network of 68,000 pharmacies where you can get 30-day prescriptions filled, which includes Walgreens. So you'll notice that Walgreens is not in the 90-day network on the left-hand side, but they're in the 30-day network on the right-hand side. And what that enables folks to do is get all 90-day prescriptions filled at any of these pharmacies on the left. 30 days they can get at Walgreens plus any of these on the left.
And so today, right now, employees today can get both 30 days and 90 days at all pharmacies, all 68,000. This would be, the only change would be removing Walgreens and Publix for when they want 90 days, okay? That's the only change. Home delivery is still available for 90 days also.
Okay. On the next slide, highlights the difference between a voluntary and a mandatory program. On the left-hand side is a voluntary program. And what that means for Rutherford County is about a $428,000 a year savings and impacts about 2,194 members by moving to that 90-day. Now, that's just for maintenance medications only. They can still get, the acute medications at any of the other 68,000 pharmacies within this network. Another option is a mandatory 90-day, which would require all maintenance medications to be filled at these 90-day pharmacies. And as you can see, the estimated savings is $990,000, impacting the same number of members. The difference in savings is we get about a 45 to 50% participation on the voluntary program. So that's why it's $428,000 versus $990,000. Obviously, on the right-hand side, the mandatory, you'd get 100% participation and realize that entire amount of savings. One point I want to make on the bottom right-hand side is the 41% higher compliance. With the 90-day fills, we typically see about 41% higher compliance because folks are getting scripts filled 4 times a year instead of 12. So your chronic diseases, your diabetes, hypertension, those types of things, you're getting better health outcomes, better compliance by getting 90 days at a time. Any questions on the 90-day option? Yes.
Yes, Ms. Stevens.
Will the pharmacist automatically suggest this to the client? So say I go to Kroger's to get my prescription filled and it's a routine medication. Would they suggest that, or is it the employee's responsibility to request that?
Some pharmacists will suggest it, and we get if there's a point of sale messaging for them to suggest that, they will. Some just do that by nature because they realize there's more savings to be had, whether it's Rutherford County or just anyone of our moms walking in off the street. It's just common practice for a pharmacist to recommend that. And if they're only being written for less than a 90-day supply, they can contact their provider and have that prescription changed.
Ms. Miller?
I have a question. Can you discuss the actual, maybe just average, or give us examples of the savings that one of our members could see if they were to participate in this?
I'm not sure.
I'm a member of cost share?
Yeah.
90-day versus a 30-day.
So if I'd been paying $10 for 30 days,
right.
if you fill it for 90s, instead of being $30 for 90 days, is it 25?
Is it percentage copay structure that you're asking about, or
So it's
flat?
based on
The copay structure.
Yes.
So two things there. One is, in doing this network, by having this, it gives us an overall better discount for all the pharmacies. We get a better discount because we've excluded Walgreens from 90 days. Okay, so they give us a better deal. So from that perspective, every script is going to be slightly less. It's going to have a bigger discount on it. And so that corresponds to what the member pays as a percentage. If on the HRA plan, which has a coinsurance, they're going to pay slightly less. But on the other plan, if I recall, is the 90 days, is it 2 times or 2.5?
Not sure off the top of my head.
Okay. So whatever we have set up for 90 days as a copay, that would be the same as what we would put in place for this plan. So they could actually see some savings from their own pocket as well.
Would the patient or the employee have to have their doctor to write the prescription as a 90-day, because the pharmacy typically would only give you what they've written it for?
Yes, they would, and a pharmacist would call that provider to have that changed.
So that's going to be some education
Right.
on the employee side then to make sure that they're aware to ask for that type of script.
And we would also provide collateral or employee communication to help make sure they understand this plan and what the options are and how it works as well.
So if we're currently getting 90 days from Walgreens, we will lose that privilege?
Correct.
And the reason being is that Walgreens just didn't agree to the contracted rates that were put forth. It's not anything that Cigna has against Walgreens, they just didn't agree to the rates.
I have a question, Chairman. So the savings that you've printed on the page here, those are Rutherford County savings. That does not capture the savings to the employee.
Correct.
Yeah, and I think, I don't know if David mentioned this, so we're looking at approximately, that's the wrong page. How many members total?
2194.
Yeah,
Almost
so
2,200 members.
almost 2,200 members, and that's total bodies, employees, spouses, children who've refilled a prescription during the last year, had received a 90-day prescription from a Walgreens or a Publix. So they would be the ones that would need to change, go across the street.
All right. Any other questions? Okay.
The next section, if you turn the page to where it says Value Prescription Drug List at the top, this is another option that Ms. Miller asked us to make you aware of, and I'll let Dave kind of go through the details of this. Currently, for Rutherford County, and what you've had in place since the inception is our standard formulary, our standard prescription drug list, the list that you see when you go onto mycigna.com and you look up a drug and whether it shows up as a preferred brand or non-preferred brand. So you've always been on our standard. Most of our book of business is. However, we are seeing a lot of movement from clients who have asked us about the prices of drugs, expensive drugs being on our formulary list. Well, we've taken another approach and developed a value formulary or a value prescription drug list, and I'll let David kind of walk through maybe the differences between that and what the impact might be if Rutherford County were to elect to use that.
Actually, on the value prescription drug list, currently, as Paul mentioned, you're on the standard prescription drug list. And what this does, there's some therapeutic classes that are excluded, a lot of tier changes where they're going from tier 1 to 2 or 2 to 3. And just to explain what the tiers are, tier 1, as most of you probably know, is a generic medications. Tier 2 is preferred brands, and Tier 3 is non-preferred brands. So what we typically see in this formulary is movement from Tier 2 to Tier 3. So some of the ones that are preferred brands now may move to a non-preferred brand. They're still covered, but just as a non-preferred product. On the particular diagram you have there, the therapeutic class exclusions, which is the biggest impact, and that's what we call the proton pump inhibitors, like the Nexiums and omeprazoles, those things that everyone's familiar with, and the non-sedating antihistamines, Claritin and those types of drugs. The bulk of the folks that would be affected by this move would be in those products that are currently available over the counter. The next thing, the tier changes, that's where we move things from non-preferred brand, second tier, to preferred brand Tier 2 to non-preferred brand Tier 3. It's a smaller group of folks that will be impacted by that, but there are some that will be affected by that. Most of them are like Synthroid. There's a generic available. Brand name Synthroid is preferred brand right now. in your population that would be moved to Tier 3. It's still covered, just at a higher tier. Then the drug removals is where we exclude a lot of the egregiously priced drugs. There's only a couple drugs that really impact your population as a whole, but last year we removed 162 drugs from this formulary because they're egregiously priced. For example, you're probably familiar with the EpiPen thing that everyone's heard about. I have an example on the next page that shows that. We still cover the epinephrine injectable. It's manufactured by the exact same manufacturer that manufactures the brand name product. It's just labeled differently. So there's some changes like that that come into play when you move to the value formulary. If you look at the bottom, it's about 1,770 members that would be affected by this, with about a $414,000 potential savings by considering the value formulary.
I have a question. On the tier changes, if a patient is taking one of those medications that you're calling a Tier 2, that would go to Tier 3, if for whatever reason their body is resistant to the Tier 3 medication, is there exclusion if the doctor, if they try the Tier 3 and it doesn't work, is there a way for them to go back to Tier 2 without penalty?
Yeah, what it is if it's not covered, we have a medical necessity review which could take place to allow that drug to be covered. If it's a Tier 3 exclusion, it's administrative override or administrative appeal. So there are two methods, either medical necessity or administrative appeal, to go through our process to get those medications covered.
What about from a Tier 3 to Tier 2? Can they get approval?
No, to get from a 3 to a 2, no, that would not. We wouldn't change the tier on a particular case. It would change the coverage, though. For example, if there's a, is that what you're asking?
I'm going to use your example of Synthroid, and I believe the Tier 3 is levothyroxine, if
Right.
I'm correct. And so someone who has taken Synthroid, if they move to the Tier 3, because that's what the pharmacy will fill unless otherwise, if for whatever reason the patient does not respond to the levothyroxine and they have problems with that and they need to go back to the Synthroid, will the employee receive a penalty for having to have the Schedule 2 drug?
The brand name?
Brand name, yes.
I don't believe so.
Would it still be?
Would it still be in the same tier?
Still be under 3?
It's still covered. It's not as a Tier 3. So your copay would be higher for a Tier 3. Is that what you're asking? Yes. Yeah, we wouldn't change the copay to go from a 3 to put it back on a 2 for a particular case. It would be priced at Tier 3 coverage, right?
One costs more, yeah.
Does that answer your question? Okay.
Yes, Mr. Jeff.
If a member has previously had adverse effects to a medication, since we've been on Cigna, would that member have to go back on the adverse?
No, that's why there's a medical necessity or administrative override options.
Back through another appeal?
No. But in the event of a new case, someone having an adverse event, we have a medical necessity or administrative appeal to override. If it's a new start, but to your point, if it's previous therapy where they've experienced that, they wouldn't need another process to override that.
Now I have a question. If it's moving from a Tier 2 to a Tier 3, and there's no way to get it go back to a 2, medical necessity will not send it back to a Tier 2. It will stay on a Tier 3. You've just got to pay more money for it. You can take your same drug. It's just you're going to pay a little more for it now because you've moved to a 3. There's no way to take it once it's moved to a 3 back to a 2, medically necessary. Okay.
And this medical necessity typically comes into play if there's an adverse reaction or something that's excluded. For example, the class exclusions we mentioned. Yeah.
Yes, sir. Are there any other questions? Yes, Ms. Christie.
So when a person needs to go on a drug that requires a medical review, an appeals process, how often does the appeals process go in favor of the person who needs the prescription versus in favor of Cigna?
Actually, it changes by drug mix, but I think our rates are in the high 80s, 88 and 89% approval for the most part, across the book, across all categories of medications. It is approved, correct.
Can you describe that process, what that looks like? Like how long from the time I'm prescribed a prescription and I discover this change, how long does it take me to get my medication?
could be instantly. I mean, if a point of sale and a pharmacist recognizes that and they contact Cigna, it could be instantly, maybe the same day. I mean, it's a very quick turnaround.
So is it on the pharmacist or the primary care physician to determine the medical necessity, to be able to make that argument for medical necessity?
Medical necessity actually goes through our, are you talking about prior auth in general or medical necessity?
Yeah, I'm talking about if I would need a medicine and the only way I can get it is with this medical necessity exclusion, how does that happen? And who does that?
It goes actually to our medical directors through Cigna, and I believe it's, what, a couple day turnaround, maybe?
Yeah, and
4 or 5 days.
And that would be something where the pharmacist would say that you need medical exception because it's showing up on their screen that drug is not covered. So that would go back to your provider, and they are very familiar with that process. It is a form that their staff is familiar with, and they would submit that to Cigna. Cigna would automatically, almost instantaneously, either review it and then submit that information to the pharmacy to have it covered. You would be able to go back and fill it.
Did I hear you say I could be up to 5 days waiting on that medicine?
It depends on the complexity. Sometimes it's the same day or instantly. It depends on if it's, simple or more complex review, or our medical director has to have a conversation with that member's provider. But that happens today, even without this value formulary. This is happening today to everyone, everyone.
What kind of provider education do you provide for physicians to help them understand this process?
Which particular process? The appeals process or
Yeah,
the
for providers to
formulary?
understand how the value system works, because I'm sure they have lots of Cigna patients. And I'm sure that there's provider relation representatives that work with the physicians. I'm just curious, how much education, how much time do you spend educating providers to make sure that they understand how to do this and to do it, more seamlessly?
Yeah, in addition to that, and also if they're on the electronic prescribing platform, it'll happen instantly right in front of them. They'll see exactly which drugs are available and which formulary, which tier it falls into, and they can make those decisions while the member is still in their office, actually.
But to answer your question, yes. So that's part of all the conversations that our provider relations are having with the providers. And now that we've moved so far into our collaborative arrangements with our physicians throughout Middle Tennessee, we are meeting with them more often, and we're actually reporting back to them the behavior of their physicians and what drugs they're prescribing, and that determines kind of their quality score and their efficiency score. So we're having more and more of those discussions with them, and so when we move clients to a value formulary, it tends to improve their results in their office as well.
One other general comment, too, on a value formulary. We have to provide medications for every class. I mean, we have to cover every class of medication. That's required by law. So it's just really narrowing down some of the more egregiously priced drugs where there's alternatives available to take advantage of those situations. So it's in the best interest of the members, providers, client, everyone involved, just to manage those costs more effectively. So there's really no drug classes that are excluded. We have to, by law, cover everything, every class.
Any more questions or discussion? Have you got some more, Mr. Paul, to go over? Okay, all right.
Last one.
Do you want to show them that? I'm sorry.
Yeah, just one
Okay.
last slide. And actually, what Cigna does every day on behalf of your members is manage these formularies very effectively. These are just some examples of egregiously priced drugs that are out there in the marketplace. Some of these are household names I'm sure you're familiar with. Shows what the actual price of the drug is compared to what the alternative is. For example, the EpiPen that I mentioned earlier, $630. The same manufacturer is making that generic. They just aren't calling it EpiPen, they're calling it epinephrine, which is on our formulary for $168. And the list goes down for the anti-inflammatories, the one for toenail fungus, the Jublia, and then Vimovo, which is kind of interesting. It's a combination of naproxen, a non-steroidal anti-inflammatory, which I'm sure most of you are familiar with, and Nexium. $2,100 if that was on a prescription. We exclude that from our formulary. You can get both those products for about $10 over the counter. So that's just some of the things that Cigna does on an ongoing basis in negotiating these contracts with manufacturers and also managing these egregiously priced drugs where alternatives are available.
Any more questions? All right, Ms. Miller, what are we needing to do with this information today?
Well, for the most part, it is information, but after discussion and looking at the possibilities of this, Mr. Elam and I discussed it, and we would like to consider putting the Cigna 90 Now benefit in on a voluntary basis so that it's not going to force the employees to do anything. And we'd like to see, with the proper education around the program, if we can't drive some savings to the county, it would be a good representation of what it can achieve. And then if we see that it's making a difference, then for the next renewal, we can determine whether or not we want to make it mandatory. And as we see that, perhaps if there's acceptance of this, there could be acceptance of the other programs. So we'd like to consider the 90-day now for 2020, and then build the other two programs in for consideration, not definitely, but to consider them for the 2021 renewal.
So you're suggesting that we stay where we're at with our pharmacy and add this as a voluntary part of our medical pharmacy through Cigna?
Correct.
Okay. All right. Is everyone aware and understand what Ms. Miller described, what we're looking for? Ms. Allen?
So is Cigna going to track the 90 Now, the folks who participate in it, and so that we can kind of gauge what that actual savings is when we go to look at it another year from now?
Yes.
All right. Any other questions? Yes, Mr. Phillips.
I know we're right in the middle of a year or just at the beginning of a year. Is it possible to implement that change July 1st and to the year?
Yes.
Why wouldn't we do that?
Well, the opportunity to put this in and achieve some savings for the county is great. We don't usually like to make plan changes middle of the year, but since this is a voluntary plan, the employee doesn't have to do it if they don't want to. It would be the education process to make certain that the employees understand that process. Usually they're not paying a lot of attention to education processes that come out mid-year. They're looking for it during the open enrollment information. And so educating now, while we could put the program in and see how it works, it would just require a special effort to get that education out, whereas it would automatically come out at open enrollment.
The flip side of that is, though, that you'd only have one particular program to educate them on instead of multiple ones that might be going through. So you may get a better response.
Possible. Can I ask Mr.
Yes.
Huffman a question?
Absolutely.
When we implement this program, does Cigna send out educational material to the members?
So for the 90-day, Cigna 90 Now is what we call it, moving them into that network. There's not a formal notification letter that we automatically send to those since it's going to be on a voluntary basis. We do, however, we can work with you on a communication piece, if you will, and discuss how we want to get that out, whether we want to pay for a mailing or do a meeting or prepare something that you put on your intranet or something like that. But am I correct? Yeah. Okay.
Well, let me ask this question. Even if it was in January, how am I as an employee going to know? Okay, wait a minute. Will my drugstore automatically do this Cigna 90 instead of running it through my regular Cigna pharmacy that they're already doing every day? This is going to kick me out because I do Walgreens. I'll just go ahead and tell you. But anyway.
Do you currently do Walgreens on a 90-day?
Yes, I do.
You do?
So, yeah.
Okay.
So you really kicked me out. So if I go to the drugstore, do I have to tell them, please run this under Cigna 90?
No.
Or will it automatically do it? If it's going to automatically do it, might be a good thing to go. Generally, we do a January start on anything like that, but it might be without, if I don't have to show them a new card or say, use the Cigna 90, they can, when they key me in, Cigna 90 is going to come up as an option.
As long as your provider has given you a prescription for 90 days, it will happen automatically, just like you fill any other prescription.
Okay.
They'll already know that.
So
unless if you go to Walgreens and take a 90-day script to them, they're going to tell you that it can't be filled, or you need to bring back a 30-day.
Yeah.
Okay, and that's
I know, I'll just tell them
all.
use the old way.
And just-
That's that point.
Yeah.
Now,
So,
let me clarify that. So you just said that if you go to Walgreens with a 90-day script, even though this is a voluntary program, if you go to Walgreens with a 90-day script, they'll tell you they can't fill it?
They can fill it, it'll be at a higher cost.
Right, but it would still be the 90 day.
You can still fill it, yeah.
So they can continue
Yeah.
filling it as they were filling it prior, you just don't get the additional benefit of the Cigna 90 now.
No, no. You can get,
This is mandatory.
well, if you, it's,
You don't have to get your drugs filled at 90 days.
Correct.
right, you could get them at 30 days at Walgreens.
Be mandatory.
You get 330s at Walgreens over a 3-month period versus 190 that you can get elsewhere. To go to Walgreens would have to break it down to 3 30-day prescriptions.
But using Ms. Hickerson as an example, who's currently going to Walgreens with a 90-day script, now she would be told you have to get 3 30-day scripts.
Right, right.
or pay the higher price.
Or pay the
Or
higher
pay the higher price for the 90.
But automatically, if I went with my 90-day to Walmart, they're going to automatically run it through this Cigna 90
Yep.
instead of the old pharmacy thing that they would see when Cigna pop up.
Still the same thing. It's still Cigna, it's still the same screens. They just know that they can fill 90 days and charge you a different copay.
Okay,
That's all.
okay. All right, I get it.
Yeah, the pharmacies on the left, it's pretty much transparent, and it'll happen automatically with, yeah.
Okay.
Okay, with that change, though, what makes this different from voluntary to mandatory? Because it sounds like you had to move the whole group over to the 90 so that everybody gets caught, not just the 2,200 people who are getting the 90-day supplies, or just the ones who, out of that 22, decide to opt in.
Yeah, so let me clarify the difference between voluntary and mandatory. So voluntary means the person has the choice to fill a maintenance prescription in a 30-day script anywhere they want, or they can fill it at a 90-day script at the ones that are in our network. Mandatory means anyone with a maintenance script has to go to the 90-day network and has to get a 90-day prescription, okay? Either that or through Cigna Home Delivery. The 2,200 that we said are impacted, we assume only half of those will do it, but under a voluntary basis. Under a mandatory basis, we assume they're all going to do it.
Well, I guess I'm thinking about Ms. Hickerson, for example. She's friends with her pharmacist. Her pharmacist knows her, likes her. She's been going there for years.
Part of it, yep.
So she's not going to be able to still take advantage of her 90-day refill, even though she didn't opt into the 90. She still can't get a 90-day supply any longer. She's going to be required to pay a
That's
copay and have to
correct.
go every month to pick it up.
That's correct.
Feels a little less voluntary now.
Well, all I can say is, based on,
I had to do it myself, even. I know the feeling.
I do appreciate labeling it voluntary, because you could start on a drug and you want to try it for 30 days and it doesn't work. I'd hate to know 60 days worth of pills was still sitting up in my cabinet. So I appreciate us being able to voluntarily, and there's a handful that's going to be affected by this if we do the 90 days. So I don't really want to see us do a mandatory, because if it's a brand new drug for me, I make my doctor start me with like 10 or 15 pills, and if I make it, then we go on to I have some that are 30 and some that are 90, just because so with that being said, me personally, I'd much rather us, if we're going to do this, do the voluntary, that we don't mandate it 90 days, everybody has to fill it.
If we are doing the voluntary, because there does appear that there's disruption, which I read it wrong. I wasn't getting that there would be disruption in this. If we do put in the voluntary, I would recommend that we do not do it until 1/1/2020, so that we can do the appropriate amount of education.
Never mind.
Good question, though. Good question. All right, any other discussion? All right, what's the will of the committee on Ms. Miller's recommendation for the pharmacy management program of going to a Cigna 90 Now network? What's the wishes of the board? Or Mr. Phillips made the motion to approve. Do I hear a second? Ms. Allen on the second. All right, any more discussion?
All those in favor of adding this to as voluntary, starting with a 1/1/20 start date, all those in favor say aye. Any opposed? Motion carries. All right. Ms. Miller, do we have any other business, or any of our members have any other business?
We have no other business.
All right, seeing no other business, do I see a motion to adjourn? Ms. Christie on the motion to adjourn, do I have a second? And Ms. Allen, and all those in favor of adjourning? And all opposed? All right, thank you. Motion adjourned.